Tēnā koutou, tēnā koutou, tēnā koutou katoa, malolelei, tawawhalawa, utanaka, g'day. Thank you for the opportunity, Simon, Gerhard, and thank you for coming. I'll cover what I can. I take no credit for many of the things that are happening. I've been an observer and a bystander of many good things happening. The kaimahi of the hawara of the area where I'm working do the everyday things, and I've sometimes kept some of the scores. Credit to colleagues in public health too. That's the bug, this is the bay. We're in the red. The whero means when we've got more challenged socio-economically, but we've got the bush and the pahurakawa also. I'll try and go in reverse order. ARF, skin, scabies, and then from the bay point of view, scabies, skin, ARF. Are we bedfellows or to blame? My philosophy has got a lot of and in it. We've got a lot of or's been given, and I think we need to treat causes, complications and comorbidities. When we think of some of Annika Anderson's wero for us, if you're whānau-centred, you certainly have got deal with all the things I'm facing today, not one pātai at a time, one problem at a time. A bit of background, climbing rates, we've seen it. Thank you to the people that have researched it. The complexities that Annika has pointed out, and others, Malachi and colleagues. Think of the complexities, family focus, housing, culturally appropriate care, adolescence, literacy, workforce development, and coordinated systems. You've all worked on different bits of this. Housing, we know, is a challenge. Housing solutions are more elusive, but we really want affordable housing. I thought that some of these have got some quite innovative possibilities. Denny Lennon's, some of the last comments was an editorial in the New Zealand Medical Journal. Oh, we're awaiting a better society. She was got a ratio of about, higher ratio than we'd now state, 9/10 of it on throats, 10% on skin. Michael's data would suggest should be at least equal. But she did acknowledge the reservoir, gas prevalence, how much we have in the community is relevant, while also believing and working whenever we can on the pathways to address poverty and inequity. As we get more challenged, there's more skin sepsis. Maori and Pacific have faced a lot of the burden. A Pacific crowded whānau or ainga has more ARF than a less crowded Pacific family, but you could still see the rates quite high for Pacific as economic things improved. And we had a higher rate. My wife's Samoan, so that's why I use the we at times. If you get to a higher rate than crowded Pāka. That's the pathway we've heard about, priming, things before. Acknowledge Simon's study. How big or how much does scabies account for? If scabies doesn't itch or we're missing it, it's probably more than we know about. And if there's heaps in the community before they get admitted, some of our data is admission data. I'd also say scabies is important for its own sake, for the comorbidities, the secondary sepsis, the strep load, because we've seen as strep load has come down in our bay, plus a vulnerable population, ARS declined. One of Simon's neat examples was a boy who was Pacific, challenged, 4% ARF risk, and had scabies added, higher risk. I'm wondering how many people in your audience haven't had scabies. Maybe that would be yes, so you've missed out, yes. Okay, and who has? Yeah, right. Now, could you leave your hands up if it didn't itch? I think itch is quite useful. I know there's lots of it, Diana points out rightly that there are lots of itchy skins, but yeah. And Who remembers their first intramuscular penicillin injection? I think also when we say that's a quick fix, then we may turn people off too. But if we have to do penicillin, we'll walk the talk intramuscularly, but it's a real weather. You've seen beautiful bugs. Daniel's shown us in a movie. I've never seen them move and dance so well. So this is what it looks like at our end of the bay. And we are B3 class diagnosticians. We get the total lesions, we've got the itch and contacts. We're not at the A plus standard of the dermatologist. And we have to thank Michael for the categories and making sure that all of them got well thought about. And we've had some wonderful whakaaro pictures of kids and different things so that whānau can recognise what progressively worse skin things look like. We've had them in te reo, we've known the size to worry about. We've had some beautiful pictures from the ministry, local artists. We've had flow diagrams for GPs and ourselves. And in the bay, if we look at our admissions with scabies, this is a 1-year picture on the left, and these are 5-year brackets on the right. So scabies is early in life, particularly these are ethnic-specific figures. And early for Maori with the second peak, a bit older, and for the elderly Pākehā. What do the people get with it? They get cellulitis in blue, impetigo, and abscesses in that age distribution. And what are the bugs that go with it? Staph more than strep early on, staph more than strep at this point, and then strep more than staph. But they both cohabit. Scabies is declining in some places, in the Bay and in New Zealand in terms of admissions. And that might be because GPs are getting cleverer, or working harder, or always worked hard, but we're getting fewer admissions. I think it's nice to know that permethrin comes from the chrysanthemum flower, and ivermectin got a Nobel Prize. But if we look at 1% prescribing, and if people use the things for the right things, then 1% permethrin for the head lice, the cuties, and 5% for the scabies. But so in our area, I think Diana's pointed out perhaps the limitations of prescribing, but we certainly can see a decline in the Bay in permethrin prescribing, and we can see a decline in the country which parallels the admission declines. This is how we get it in New Zealand. Paediatricians have to beg from a dermatologist, an ID or a microbug, but we get on the phone and say we're about to prescribe and they nod. But it does make it not so accessible. So ivermectin scripts have been fairly stable, but the ratio suggests that people are having a lower threshold to use ivermectin. So if there is resistance, that's perhaps a measure of either resistance or persistence. For whom are skin infections declining in the country? Particularly the 1s to 4. So that would parallel the scabies decline. And in the Bay, the preschoolers' infections are coming down. They're still high, but they have declined. And where is progress being made? In the Eastern Bay particularly has come down more than some of the other areas. With statistical significance, the colours have changed, I'm sorry, but the Bay has declined more than lakes. We know the CAUs where the skin infections have come down. And the overall trend, so while there's an element of neglect, you could also say there's elements of success. Now, if we took all the last 20 years of scabies admissions and ARF admissions, and we saw when and if it matches. There were 2 kiddies. One girl came at age 12 with scabies and ARF at the same time, similar to the Auckland study, but only one in the last 20 years who had the 2 coinciding as Simon saw. We had a Pacific girl in Tauranga, had 3 scabies admissions, 5, 8 months, 10 months, and then 11 years later she gets admitted. Now, we could be underdiagnosing, we admit that, but we certainly know coincidental admissions are rare. And if we took ED presentations, one more, with a 5-year gap between scabies and ARF. This is a pathway we're thinking about, and in our area, how are they connected? I worked out a scabies prevalence from admission prevalence, but it could be much higher based on the community studies, and Daniel's studies have been real impressive to see how much we might be underdiagnosing it. But it seemed to account on a known basis for 2% of Auckland's ARF people there had a scabies admission. I shouldn't say preschools, I should use the word schools there. But in the Bay, the comparable figure was we had a higher scabies prevalence probably, and if we counted only those children, this is ethnic specific, who had a admission with scabies and a close admission with rheumatic fever, we'd have about 2% accounted that way. If we said ever having a scabies admission and later having rheumatic fever, it would be about 5%. And if we included ED and admission for rheumatic fever, we would have 7%. So it does account for a slice, but we believe with the school programs having reduced the Eastern Bay's ARF by 60%, that it's in that unaccounted 40%. That's more a comment for later. The length of admission gives a good opportunity to pick up scabies in our children. The average child comes for 2.5 days, but somebody with rheumatic fever comes a median of 13 or a mean of 17 days, and in Auckland's 23 or 54 days. So there's a good chance of looking at the kitty while they're on the ward, on an everyday ward round. The temporality which people talk about, there is a lag between, say, serious skin infections and scabies being early on and rheumatic fever being later. Like here's our ARF figures for the Bay. 5 to 14 we should expect. So if we look at the Bradford Hill type criteria, you've got a strength of association, but both share crowding and all those challenges. And we may be missing some in the community, and if we looked at every ARF for their previous prescribing, that's what I've planned to do out of the discussion so far, but there is a time lag. The consistency for scabies and ARF, it only needs to explain some of it, because by dealing to sore throats and skins, the area we can lower the ARF rate. Hence, this is not a trial, but we have, by implementing known strategies, we can see in communities where we've lowered them. We've done part due to scabies for sure, but the other part's been through to throat and skin. So I think our little area might be a tauira, an example of what can be done. Now I've got a longer argument, we can have some other time. There is like the Kuta Kaupapa or Waiaweka near the gorge heading to Gisborne. That's a picture of them celebrating their successes with rheumatic fever. And we've got a 60% Eastern Bay decline in ARF from 148 to 58, and good confidence intervals about it. We'll eventually get it accepted for publication, and that's a sort of decline. And then alongside, in a vulnerable population, the gas prevalence, the actual amount of gas that's in people's throats, comes down when you've got school programs, and even more so when there's skin implementation. So that's pre-acknowledging that a bit of both works. It's a question of and, it's not a question of or. Now, comorbidities I think are important, because if you look at what people die of, we have people in there, a third of our deaths with rheumatic heart disease were before 50. So the comorbidities that people face, they're lung, diabetes, ischemic heart disease, the added heart diseases that people get on top of their rheumatic, and then diabetes and other issues. So that saying, Fina Cooper said about 1990, we are sewing things together, so to speak. The co-design is going to be important, treating both skin and scabies and throats, helping people with the comorbidities, advocating for housing. I've wondered whether kāinga ora might become a political advocacy at times towards the housing as a top priority. It's probably on Michael's agenda and his colleagues in Wellington. I think they've taken the pedal off in the promotion, and that's one factor I'm concerned about, and they might change the language to strep A, whatever the weather, wherever, or something like that. And if you focus on scabies, and I think the word that might have come back to me might be, if we check from the prescribing patterns on the kids that we have admitted with So we've got only 120 over quite a while. We could look back, they've only been recording community prescribing recently, so about half of them would be able to check if they've ever had scabies medications prescribed before, and we won't have a control group. Prospectively, we certainly have enthused us about dermoscopy, PCRs, we look forward to that. And then when you think about if we've got to deal with skin better, somebody's going to have to work out how long do you have to prescribe to treat a skin infection, and how much and how long to effectively prevent ARF. Another thought is to people that have got the epidemiological skills could look at the communities such as ours where ARF is genuinely declining and see whether their skin rates are falling as ours are. So when the two things are happening in parallel, throat and skin being treated, you may find that those DHBs, the ARF, are declining, and where they're out of sync, you've got a problem. So that's a hypothesis. We certainly see some people that bypass the clinical presentation of ARF and they turn up with rheumatic heart disease. Further in the proximal part of the pathway, immune priming, that's going to be important that people look at that. Like if those early infections are making that amount of difference, it will be quite important for their own sake, but also for later issues. So I've commented on that. So this is what it looks like on our ward sometimes, often with secondary infections. It's difficult to miss that, but we might miss other ones. So my summary would be, address scabies on the path to health equity. It's important for its own sake and for its comorbidities. We deal with secondary infection, the staph and other things, Kefalex and Steatotorix and flu pox with young kids. Strep loaders share, and as we get less skin sepsis, we get less throat colonisation with gas. So we know that the two are intimately connected. So whatever route you get to rheumatic fever, it's worthwhile learning for both. And we've seen the throat prevalence decline as our ARF declines. I mean, not for nothing, and we've got the Dunedin community runs 23% at one point of ARF colonisation, but it's got some other bits missing out of the link. And my mother got ARF in Dunedin, and so Tauiwi are not immune. Okay, so my summary for the moment is that admitted scabies is associated with 2 to 7% of Bay of Plenty ARFs. There's more studies in terms of thinking, is the community diagnosed scabies linked to ARF admission? And certainly, is scabies active in the people that don't meet the Delphi criteria, or Delphi positive, have we missed some in our ARF kids? So you've given a good challenge, so thank you.